Just messages all in all the groups that we have started. All right then. So hi everyone. This is so amazing to connect with you after quite some time. It's the fag end of the year, and it gives me immense pleasure to connect with all the MD, DNB, medicine, and pediatrics residents of throughout the country. It is a great news for you all that we have come up with a very unique program for you all, which is a postgraduate residency program. So this is one of its kind where all the super specialists of each subject shall hold your hand and shall take you through the journey of your postgraduate residency, and with a lot of theoretical and practical teaching will take you across the sea of your postgraduate residency. Now, I do know that in very many institutes, especially the DNB institutes, the academic program is not that well developed. Okay. So to say that, regular classes are not conducted, and regular interactions don't happen, bedside teachings don't happen. So here we are at doc tutorials with a 360-degree program. So, sir, why do you call it a 360-degree program? I shall tell you. Yeah. So this was the program I was talking about. And sorry, just a moment. Yeah. So I was talking about the 360-degree postgraduate residency program. And what are the things that we have included? I hope I'm clearly audible. If yes, just give me a thumbs up. I hope I'm clearly audible. I was talking. Yeah. So, sir, in this PG residency program, in this postgraduate residency program, we have super specialists of each subject teaching you your individual subspecialty. So I, as a nephrologist, will be taking your nephrology. A cardiologist, Dr. Kamal Sharma, will be taking your cardiology. Dr. Rahul, the neurologist, will be taking your neurology class, and so on and so forth. You have both recorded and live lectures. You will be getting a practical practical case based approach. So what do you mean by that? For example, the case that I will be dealing with you today as well, that a case of hyponatremia. So you all know that there are a lot of theories written about hyponatremia in, right from your MBBS days. But I shall be teaching you how to approach a case of hyponatremia if you get it in a ward, in an ICU. What are the reports you should send? and how you must treat it, how you must approach treating it, because practical things are often different as they appear to be. You will also be getting journal clubs. We will be helping you with your university papers also, the university papers of the main universities and the DNB medicine papers. We shall be trying to give you the solutions of them and help you solve those questions with adequate references. We shall be telling you, it is practically impossible for a medicine resident, because that's a problem I also faced, to go through the international guidelines of each subspecialty. For example, in your cardiology, you have the American Heart Association guidelines. In your endocrinology, you have the ADA guidelines. In your nephrology, you have the KDIGO guidelines, because the textbooks get outdated with time. So we will teach you guideline based management of each and important disease. Are you getting us? Because that is what is important. You could read the theory from the textbook, but the management part, which is lacking even in Harrison's textbook, that we will be teaching you. All right. So, also we will be recording a few bedside discussions for the important cases which are often asked in the MD DNB practicals, and we shall be teaching you them as well. That we shall be doing it bedside only with a live patient in a live hospital. All right. Now, the case or the important thing that I have chosen for you today is one of the practically most important or most common electrolyte disorder that you encounter in your day-to-day ward, medicine ward, be it the ICU, be it anywhere, is your hyponatremia. And I am not going to teach you the theoretical aspect of it, because this can be an never-ending class. I will be teaching you only the practical approach to hyponatremia, as to how to approach a patient of hyponatremia. So, without much ado, let us dive straight into a patient. So, this was actually a patient who was a 60-year-old patient who was an 80 kg of weight, a male with heart failure. So, heart failure, pedal edema, and pulmonary edema. Very common. You are getting this patient in and out in your emergency. And the patient had gained about 10 kgs of weight. He gets intubated on arrival due to pulmonary edema. So this is a patient of acute decompensated heart failure, ADHF, which is the latest terminology. And the patient is started on a furosemide drip, a furosemide infusion. So I gave him a 40 mg IV bolus of Lasix and a 5 mg per hour infusion of Lasix. The patient had a very good urine output and started to have an output of 150 ml per hour. Wait. Yeah. So I hope you can see this now. So now, after he started having good diuresis, his initial sodium on admission was 140. Next day, it rose to 146. And the next day, it rose to 153. The diuretics was continued and the patient was good. The patient was decongested with a good output of 3.6 liters. Now, you have a patient of hypernatremia. Now, just see, now what will you do? Will you stop diuretics? Then you will worsen the heart failure, worsen the pulmonary edema. If you stop diuretics and give free water, that could add insult to injury. You continue diuretics and no free water, then the patient will land up with more severe hypernatremia. And if you continue diuretics and also give free water. So you take out water from here and you give free water from here. What will you do? What is the consensus? Can I get any options? Can I get in the answers in the chat box? Can I expect some answers there? Now, while all of you are thinking, let me take you back to physiology. Now, first and most important, there are two terminologies. One is osmoregulation and two is volume regulation. Please understand there are two different physiological processes, osmoregulation and volume regulation. Now, osmoregulation is actually depending upon the osmotic content or the osmosis, and the volume regulation is actually non-osmotic. Okay. Now, please remember that osmoregulation or osmotic, the principles of osmosis actually depends on the sodium concentration. It actually depends on the sodium concentration, whereas the volume regulation depends on the total sodium content. Sir, are these two different? I never knew it. Yes, they are different. Please understand it. Osmoregulation, which actually is a determinant or a function of sodium concentration. Now, what happens? When you have increased osmolality, osmolality is actually sensed by osmoreceptors which are in the hypothalamus. What does it do? The effector organ, which is the hypothalamic osmoreceptor, it senses increased osmolality. And what does it do? What is the effect? The effect is increase in thirst and increase in ADH. Of course, what comes first? Of course, it is the ADH that comes first. Thirst is one of the last resorts when the serum osmolality has increased by, say, above 300 milliosms per kg. First is the ADH that is to rise, and ADH will cause water reabsorption, and thirst will cause water intake. Now, please understand, this water reabsorption and water intake will thus cause what? Disorder of sodium. So actually, what you guys understand as dysnatremia or hyponatremia or hypernatremia, is it a disorder of sodium? No, my dear friends. Hypo or hypernatremia, that is dysnatremia, is actually a disorder of water intake or water reabsorption. Please understand this. This is a very, very important concept that I'm trying to give it to you. Am I clear? On the other hand, volume regulation, which is non-osmotic, so if the effective tissue perfusion, if it is increased or decreased, it is sensed by what? Macula densa, the afferent arterioles, the carotid sinus, and the atria, and it gives rise to RAS activation or suppressed ANP or related peptides, which again causes the increase in ADH or increase in noradrenaline. And thus, it causes what? Volume overload or volume depletion. So please understand, the volume disorders are actually determined by the sodium content of the sodium content of the body. Am I clear? Am I totally clear? If you are not, I'll explain you further. Now, please look at this beautiful table. Osmoregulation actually senses the plasma osmolarity, whereas volume regulation, which is a function of total sodium, I told you osmoregulation is a function of sodium concentration. It actually senses the effective circulating volume. Now, what senses the osmolarity? I've already discussed the hypothalamic osmoreceptors. And the effective circulatory volume is judged by the carotid sinus, the afferent arteriole, and the atria. Osmoregulation, judged by the osmosis, judged by the osmoreceptors, actually causes what? Increase in thirst and increase in ADH. Whereas the effective circulatory volume, which is judged by the carotid sinus and the afferent arteriole, it causes what? Activation or suppression of the RAS, ADH, and sympathetic system. What does osmoregulation affect? It affects the water excretion or the water intake, and it causes hypo or hypernatremia, as I've already told you. Whereas volume regulation affects what? The urinary sodium excretion, and it causes volume depletion or volume overload. I have clearly depicted to you this today. So, my dear students, what I'm trying to tell you is sodium disorder is actually a disorder of water intake or water excretion, and it is not a disorder of sodium intake or sodium excretion in most of its pathophysiology. Now, as I told you, what happens is with the percentage change in your osmolality, you can see that when the serum osmolality changes, when the serum osmolality changes by 5 to 10%, what happens is your your the arginine vasopressin does not change much. So this, the plain circles, is actually isovolumic osmotic increase. So here the volume does not change, but the osmotic, but the plasma osmolality increases. Whereas in the second one, it is the isotonic volume depletion. So here actually the tonicity remains the same, but the volume decreases. Now have a look here. In the initial 5 to 10%, the AVP almost remains the same. The AVP almost remains the same, after which it increases exponentially. Exponentially. So I told you that in the first 8 to 10% change of the serum osmolality, vasopressin does not increase much. So now, as I told you, here you had, coming back to our original patient, you had two simultaneous pathophysiological processes going on. One was a disorder of total body content of sodium, which is actually the content of, which actually is a problem of the water regulation, and one was a defect of osmoregulation. So osmoregulation caused hypernatremia, and your volume regulation caused volume overload. And that is why you have to treat both of them simultaneously and separately. So you need to treat volume overload with diuretics and hypernatremia with free water. I hope I'm absolutely clear with this question to all of you. Now, coming to our topic. So this actually was a basic actually was physiology for you. I was trying to explain you what is the concept of osmoregulation and volume regulation, and what are they governed by, and what are the effector and the effector organs. Now, how do you approach hyponatremia? So for that, let me tell you what is hyponatremia. Hyponatremia is serum sodium less than 135 milliequivalents per liter, or less than 135 millimoles per liter, because it is a univalent cation. So the milliequivalent per liter and millimoles per liter is absolutely the same. I hope I'm clear here. Now, how do you approach hyponatremia? Now, students, you have been given a chart of approach to hyponatremia where they start with your hypovolemic hyponatremia, euvolemic hyponatremia, or hypervolemic hyponatremia, and on the basis of urinary sodium, they tell you what is what. But actually, that is very, I have tried to implement that in practice, but I have never been able to judge it, because more often than not, judging the volume is only not that easy. But because hyponatremia is a much complex process. So today I will give you a approach to hyponatremia, which if you follow, you will never miss a case of hyponatremia. But before that, let us start with a case, so that you know, again, this is a practical live case that happened, and you know that how to get it implemented in your practical case-based approach. So a male patient with cirrhosis, alcoholic cirrhosis, presented for esophagogastroduodenoscopy, basically upper GI endoscopy, part of a liver transplant workup, and was known to have edema and an asymptomatic serum sodium of 128. So he was found to have a sodium of 128, and he was evaluated with the serum osmolality, urine osmolality, serum sodium, urine sodium. That is what we sent. So we sent a couple samples of both urine and serum, and we sent osmolality and sodium in both. He was found to have serum osmolality of 260, a urine osmolality of 450, urine sodium of 80, and he was not on diuretics. Of course, the serum sodium was 128. So what do these figures, are these jargon, or are they just sent for the sake of sending? You know, I also used to send it in the first year of my residency. But Honestly speaking, I didn't understand the importance of it. So what is actually the mechanism or the approach to hyponatremia? So now I will give you a flowchart today. Please remember this lifelong. And if you remember this, you will never ever falter anywhere. Okay. So if you get a low serum sodium that is less than 135 milliequivalents per liter, the first task is to check for serum osmolality. Now, the serum osmolality can be low, it can be normal, it can be high. So the if serum osmolality is low, if the serum osmolality is low, then what do you do? That is known as a hypoosmolar hyponatremia, and that is a true hyponatremia, because if the serum sodium truly decreases, then the osmolality will fall, and that is a true hyponatremia or hypoosmolar hyponatremia, and that is the hyponatremia that you should be concerned for, that is which requires your treatment. Because if the serum osmolality is normal, then and your serum sodium is low, then it means it is actually not a true hyponatremia, that is a pseudo hyponatremia. And when does pseudo hyponatremia occur? I will teach you in detail. The common causes are hypertriglyceridemia and hyperproteinemia, like in multiple myeloma. So basically, if the solid part of the blood increases and the plasma component remains same, it is it can cause pseudo hyponatremia. It is actually a laboratory measurement artifact. It is not a true hyponatremia. Am I clear? That is why it is known as a pseudo hyponatremia. If the serum osmolality is high, then that is called as a translocational hyponatremia. What is that? Sir, if a patient has hyperglycemia, if the patient is given mannitol, what can that do? Sir, that can cause a translocation of sodium from the extracellular fluid into the intracellular fluid, and that can cause a translocational hyponatremia, which is again not a true hyponatremia. So you need not bother about that. So first and foremost, what I'm trying to tell you again and again is that you are bothered only with true hyponatremia, which is hypoosmolar hyponatremia. After you have confirmed that it is a true hyponatremia, your next task is to see the urine osmolality. If the urine osmolality can have two things, it can have an urine osmolality of more than 100, or it could be less than 100. Sir, if it is more than 100, then my urine is getting concentrated. So now, if you ask me, sir, what is the normal range of urinary osmolality? So urinary osmolality can range between 15 to 1200 milliosms per liter. Am I clear? Somewhere between 50 to 1200 milliosms. Now, if the urine osmolality is more than 100, it means that the urine is getting concentrated. If urine is getting concentrated, who is concentrating the urine? It is the ADH. So it means ADH is present. ADH is present. If your urine osmolality is less than 100, it means either the ADH is absent, or I have had so much of water, or I have extraneously suppressed my ADH by having excess of water or excess of solute-free liquids. And that has two important causes, which is nothing but beer potomania and primary polydipsia. So in primary polydipsia, actually what is happening is I have suppressed ADH by drinking lots and lots of water. And second is beer potomania, where see beer is considered to be a drink which has very low amount of solute and is mostly the water. So there, some people in the Western countries, they survive only and only on beer. They consume, 4, 5, 6 liters of beer per day. And that will lead to excess of free water accumulation in the body, and that will suppress your ADH, and that will cause a hypoosmolar hyponatremia with a urine osmolality of less than 100. And this could be compared to a tea and toast diet in Asian countries. People who consume only tea and toast, that also is similar to your beer potomania, which has very low solute. So next task is to see your urine osmolality. Now, if your urine osmolality is more than 100, and if ADH is present, then what do you do? Then, sir, my next task is to see urinary sodium. This is my next task. So if the urine osmolality is less than 100, that part of the flowchart is finished. If the ADH is present, then I will look at the urinary sodium. Why? Because if my urinary sodium is less than 20 or it is more than 20. If it is less than 20, it could be a true volume depletion or an effective volume depletion. Just a moment. Yeah, I'm so sorry for that hitch. Can you see me now? Can you hear me now? Please give me a thumbs up if everything's fine. Yeah. So now, if your urinary sodium is less than 20, it could be a true volume depletion or an effective volume depletion. A true volume depletion is where your extracellular volume is less. That could be in your GI fluid loss or your third spacing. Or if it could be an effective volume depletion where you're actually the extracellular fluid is expanded, like in heart failure or cirrhosis. If your urine sodium is more than 20, then your ECF could be reduced. It could be in primary adrenal insufficiency, cerebral salt wasting, renal salt wasting. Or if your ECF is normal, it could be your SIADH, hypothyroidism, and hypocortisolism. Of course, you have to exclude CKD and diuretics here. I hope I am clear with this flowchart. And if in life you follow this flowchart, I can guarantee you, you will never miss a case. So actually, you have to approach hyponatremia in 4 steps. I repeat, step number 1 is your serum osmolality. Step number 2 is urine osmolality. Step number 3 is urine sodium. Step number 4 is volume status. If you know how to do these 4 sequential steps, you will never miss a case of hyponatremia. Why, sir? Can you show me an example? Yes, I will show you an example. But before that, I was teaching you about pseudo hyponatremia. Now just have a look. This is a normal serum of a patient where this is the water content where you have sodium, and this is the protein and the lipid. And say this is the cellular content of blood. In your hyperlipidemia or hyperproteinemia, what happens? The plasma volume remains the same, but your solid component, which is the protein or the lipids, that increases. But remember, the sodium content is remaining absolutely the same. But because the the solid part increases compared to the water content, if you see this, if you measure sodium by an old redundant method, what will happen? You will get a pseudo hyponatremic picture. You will get a pseudo hyponatremic picture because, say, a previous method like a flame photometry, what happens? That would measure sodium with respect to all compartments, and that would measure it falsely low. But a direct ion selective electrode method, that will measure sodium only in the aqueous phase. Only in the aqueous phase, the direct ion selective electrode method. And that will actually will not measure, or that will not take into account the pseudo hyponatremia. So this is about the pseudo hyponatremia. Now coming to that same question and the answer for that. So let us go back to our flowchart and find out the answer. Okay. So our patient had a serum osmolality of 260, urine osmolality of 450, and urine sodium of 80. Now come to this flowchart. Come to this flowchart. Yeah. So a serum osmolality of 260. What do you think? This is a high serum osmolality or a low serum osmolality? Of course, this is a low serum osmolality, less than 270. So this is a true hyponatremia. So you have entered the flowchart. Next, check your urine osmolality. Urine osmolality was around 460. So it is less than 100 or more than 100? It is more than 100. So the patient has an active ADH which is present. So this cannot be polydipsia. This cannot be beer potomania. The next task is to check for urine sodium. In your urine sodium, it was 80. Your urine sodium was 80. So what can this be? Can this be a primary adrenal insufficiency? Not at all. Cerebral salt wasting does not go with there. Renal salt wasting, no. The next thing, the patient also had edema 2 plus. Please remember, the patient did have edema 2 plus. Okay. Now, this cannot be the options here. Coming to your options, it could be SIADH, hypothyroidism, or hypocortisolism. Going with the question, of course, what goes in favor is SIADH. Is SIADH. Am I clear? Am I absolutely clear? So this patient actually had hyponatremia due to SIADH. I hope I'm absolutely clear to all of you. Okay. Now let us go to another case. A 40-year-old female admitted for appendicectomy has been receiving 5% dextrose, half NS at 100 ml per hour. So receiving basically a hypotonic solution or free water. 5% dextrose is actually free water, 100 ml per hour. Post extubation, she had significant pain, nausea, and unable to eat much, and so she was continued on IVF. Next morning, she is found to be altered, incoherent. Labs show a sodium of 115, and she has a weight of 60 kgs. How will you manage her? Will you restrict free water? That is an hyponatremia. Of course not. That is an SIADH. Will you do that? Will you change the IVF to NS at 100 ml per hour? That could be done. Would you give 3% hypertonic saline? Or will you give free water restriction and 3 gram salt tablets TID? Now, what you got to understand that this is a patient of hyponatremia, and when you treat any hyponatremia, you have to take into account two things. Number one is the rapidity and the severity of hyponatremia, and number two is your symptomatic hyponatremia. So two things is that whether the patient is symptomatic or not. If the patient has symptomatic hyponatremia, then you've got to be a bit aggressive. And second, and very important, the rapidity or the acuteness of hyponatremia. So here, of course, the patient developed hyponatremia in less than 48 hours. So it was relatively an acute hyponatremia, which was symptomatic. The patient was having an altered consciousness. So you cannot, first of all, be treating this patient with a free water restriction alone. You cannot be treating this patient only with a changing to normal saline, because you've got to rapidly increase the sodium here. So the best treatment would be 3% hypertonic saline. 3% hypertonic saline is the best treatment. And of course, the rate of correction is, of course, 8 to 10 milliequivalents in the first 24 hours and less than 18 in the first 48 hours. Now, coming to another question. A 24-year-old male who is a 24-year-old male who is an alcoholic presents to the emergency after being found down by the family. He has a blood pressure of 120 by 80 and appears euvolemic. So he's euvolemic, an alcoholic having a normal blood pressure, and he's found to have a serum sodium of 128. So again, there is hyponatremia. The serum osmolality is 265. The urine osmolality is 60 and the urine sodium is less than 10. How will you approach this patient? Anyone who could answer from the audience, from the chat box, I would want to see. I've already taught you the algorithm. Now, can any one of you approach this for me? Let me see. Let me see. What do you say? Come on, guys. I want at least a couple of answers in the chat box. Come on. Yes, I'm waiting for some students to at least attempt it for me. Should I do this for you? Chalo. I think after this case, you'll be more confident. So this was our flowchart, yes or no? So this gentleman has a serum sodium of 128. So it's of course a low serum sodium. Of course, a low serum sodium. The serum osmolality is 265. The urine osmolality is 60. And the urine sodium is less than 10. This is the question. So now the patient has a low serum sodium, yes or no? Yes. So there is hyponatremia. Serum osmolality is high, normal, or low. It is low. So this is a patient of true hyponatremia. We have already come to the second step. Next, you've got to check the urine osmolality. If it is more than 100 or it is less than 100. It is only 60. So it is less than 100. When the urine osmolality is less than 100, it means the urine has been maximally diluted. Why? Because the ADH has been suppressed. Now the patient was an alcoholic. So what do you think the patient was? I told you only two reasons for a patient to have hyponatremia with a urine osmolality of less than 100 is polydipsia and beer potomania. So here, yes, the answer will be beer potomania, because the patient has consumed too much of solute-free beer. Am I clear? Absolutely clear. See, I just plotted this in this graph and the answer came to me automatically in this flowchart. Now you would say, sir, why is the patient having a low urine sodium? Because the patient consumed so much less solute, there was very less solute to be excreted. And that is why the urinary sodium was less than 10. Am I clear? Now, for those who have still not understood what is about this urine concentration and the ADH action and beer potomania, let me tell you a simple example. Say, for example, a normal person consumes a solute of 600 milliosms per day and he consumes 1 liter of water. So, to excrete 600 milliosms of solute, he will produce what? He will produce a urine volume of 1 liter, which has, of course, in 1 liter, if one has to excrete 600 milliosms, the osmolality will be 600. So the ADH will be adjusted and the net water balance will be 0, because our body usually wants to be in a net homeostasis balance of 0. That is water homeostasis. If this patient consumes 2 liters of water and 600 milliosms of solute, so to balance 2 liters of water intake, the patient will produce 2 liters of urine, yes or no? Now, this he will have to excrete 2 liters of urine ke andar 600 milliosms. So how much solute will he excrete in each liter of urine? 300 milliosms in first liter and 300 milliosms in second liter. So the urine osmolality will be 300 milliosms per liter of urine. Net water balance, 0. Come to another patient. He is having 6 liters of water. He's having tremendous water. But water solute content is only 600 milliosms. So now, to balance 6 liters of water intake, he will excrete 6 liters of urine. Now, to excrete 6 liters of urine, he must excrete 100 milliosms in each liter of urine. So 100, 100, 100, 100, 100, 100, and the net osmol excretion and the water excretion will be equal. So the urine osmolality will be quite dilute. He will dilute his urine so that each liter excretes only 100 milliosms per liter of solute. And the net water balance is 0. Till here is absolutely fine. Now comes the funny part. A patient is consuming lots and lots of beer. How much beer? He has taken 4 liters of beer. 4 liters of beer has only 200 milliosms of solute, because I told you it's a solute, relatively solute free drink. Now, to excrete 200 milliosms of solute, you know that the maximum dilution that one can do is 200, rarely 50, mostly 200 milliosms. Now, each liter will excrete only 100 milliosms of solute. So, 200 will be excreted in 2 liters of urine. And net what? He has gained 2 liters of water. He has gained 2 liters of water in his body, and that will cause hyponatremia. Yes or no? Coming to primary polydipsia, this guy has had 14 liters of water, consumed 600 milliosms of solute. Now, if he maximally dilutes his urine, that may be say 100 milliosms, he will be excreting that 100 in only 6 liters of urine. Yes or no? But still he will be gaining 8 liters of water every day, and that will cause dilution hyponatremia. I hope I'm absolutely clear to you. This has been, this should clear all your concepts regarding hyponatremia. So now coming to the basic theoretical part, you know that the normal serum osmolality is 282 to 90. In some books, 275 to 285 milliosms per liter. Serum sodium is less than 135. Acute hyponatremia is hyponatremia developing within 48 hours, and chronic is more than 48 hours. So you divide hyponatremia into severe, moderate, and mild depending upon the serum sodium. So if the serum sodium is between 130 to 135, that is mild hyponatremia. If it is between 125 to 130, that's moderate hyponatremia. And with less than 125, some books say less than 120, that is severe hyponatremia. How does hyponatremia present to you? A mild hyponatremia may be asymptomatic. The patient may have a slight headache, irritability, difficulty in concentration. A moderate hyponatremia can have nausea, confusion, disorientation, altered mental status, unstable gait, elderly person, falling recurrently. It happened with my own grandmother. So my grandmother was falling again and again, and she's also a patient of Parkinsonism. So, even I was overlooking that to be maybe due to Parkinsonism, she was falling again and again. Then, my aunt called me and said that Vivek, she's fallen like 3, 4 times, and her gait is also very unstable over the last few days. And suddenly I realized that she was on a chlorthalidone for hypertension. I immediately checked serum sodium. It was only 123. I stopped the thiazide diuretic, supplemented the sodium, and she improved, and gait also improved. So gait disturbances, mood disturbances, irritability, nausea. So the beautiful part is, some patients, especially CKD patients, may have a severe nausea or vomiting that can be caused due to hyponatremia. So hyponatremia can cause nausea, vomiting, and vomiting can cause hyponatremia. So it's a vicious cycle. And severe hyponatremia, of course, can cause altered mentation, seizures, stupor, coma, confusion, and everything. Coming to a very, very important clinical entity, an ill understood entity, that is SIADH. Now, what is SIADH? See, I'm trying to give you the concept and not only the theoretical part. See, ADH is actually what? Anti-diuretic hormone, ADH. So it actually antis or antagonizes the excretion of water in the urine. Hence, it causes a concentrated urine. Hence, it causes decreased urinary volume. So ADH causes two things. Number one, it increases urine osmolality because it causes urine concentrating, and it decreases urine volume. So this is the two functions of ADH. Now, higher the ADH, more concentrated is the urine. In most patients, the SIADH ingestion of water does not adequately. So, if I increase my water intake, my body will do what? It will not try to decrease the water excretion in the urine. It will try to excrete more water. Hence, the best way to suppress ADH is take in more water. But the disease is, but this is physiology. But in pathological condition like SIADH, SIADH is syndrome of inappropriate. What do you mean by inappropriate? Where the ADH does not get suppressed by water intake. So here in SIADH, water intake does not suppress ADH and the urine remains concentrated. This leads to what? Water retention, increases total body water, and that lowers the sodium and causes hyponatremia by dilutional hyponatremia. But that is not all. Most people think that's all. No. The total body water increases, it expands the extracellular volume, triggers urinary sodium excretion. So it also causes urinary sodium excretion, which returns the extracellular fluid volume to normal and further lowers the plasma sodium concentration. See, many students ask, sir, if SIADH causes what hyponatremia by dilution, why is it a euvolemic hyponatremia? It is a euvolemic hyponatremia because by expanding the extracellular fluid volume, it causes increased urinary sodium excretion and thus balancing the ECF volume, and it causes further lowering of the serum sodium. I hope this is absolutely clear to all of you. Now, in SIADH, an increase in water intake does not produce an increase in water excretion. I told you, because the ADH release is relatively fixed. So in SIADH, you have a relatively fixed ADH release and you have a relatively fixed urine osmolality. Please understand this. So a person excretes a urine osmolality which is relatively fixed because the ADH secretion is fixed, because the osmostat is reset. It is not being perturbed by water intake more or less. So now a patient who has ADH with a urine osmolality that cannot be reduced to below 750. So whatever you do, your urine osmolality is fixed at 750. Okay. In this patient, the urine output will be determined by the rate of excretion of solute. Yes or no? Of course, yes. So now, is this patient consumes, it's a Western patient and consumes, say, 750 milliosms of solute, all of which are excreted because he is having a urine osmolality of 750. So all of which are excreted in the urine each day. With a fixed urine osmolality of 750, the daily urine output will only be 1 liter because the urine concentration will not come down below 750 and he's consuming 750. So what? He will produce only 1 liter of urine. If he consumes 2 liter of water, that will not cause 2 liters of urine. That will only cause 1 liter of urine. And then what will it cause? It will cause extra 1 liter of water building up each day. And that will cause what? That will cause dilutional hyponatremia. Is this clear to all of you? Is this absolutely clear to all of you? Yes or no? Yes. So now, if I consume a low solute diet, supposingly this patient was consuming a solute of 375 milliosms per day. Now what? His urine osmolality would never go below 750. So he would excrete how much? He would excrete only, he had a solute intake of only 375. So now he would be doing what? He would be actually going into a negative water balance. And that is why we restrict free water in SIADH. If you've still not understood, I have a better and clearer example for you. Now just have a look here. A normal patient, I told you, consumes 600 milliosms of solute, takes 1 liter of water, will produce 1 liter of urine with 600 milliosms per liter of concentration in the urine. If the same person consumes 600 milliosms of solute in 6 liters of water, he will produce 6 liters of urine with 100 each concentration. Now, if a person of SIADH consumes solute of 600 milliosms, he has a urine osmolality which is fixed at 200. What will happen? He consumes 2 liters of water. He will produce 3 liters of urine because the urine osmolality will not change to 300. It will be remaining at 200. And to excrete 200, he will be having what? 3 liters of urine. So he'll be having a net water balance of minus 1 liter. This patient, if has a water intake of 2 liters and he has a urine osmolality fixed at 400, say. So to excrete 400, he will produce only 1.5 liters of urine. So he will have a net gain of 0.5 liters. And if he has a urine osmolality fixed at 600, then what happens? Then he will excrete only 1 liter of urine. So he will gain 1 liter of water each day. That is why to treat SIADH, you should do most importantly what? You should restrict free water. Because if you restrict free water, the urine osmolality is already high. There will be no extra gain in water in the body, and that will not cause worsening of the hyponatremia. Now, causes of SIADH, you have been studying and you know it all. It is the different carcinomas, very importantly, the lung cancer, different lung disorders like the pneumonia, the bacterial abscess, the asthma, pneumothorax, cystic fibrosis, tuberculosis, CNS disorders like meningitis, encephalitis, head trauma, brain abscess, subarachnoid hemorrhage, any hematoma, trauma, any delirium, or other disorders like the AIDS, exercise, porphyria, and some important drugs, mostly the SSRIs, the tricyclic antidepressants, cyclophosphamide, chlorpropamide, and all these drugs. So this is the Barter and Schwartz criteria for SIADH, where the patient has hypotonic hyponatremia, so he's having a true hyponatremia. He has euvolemia because it's a euvolemic hyponatremia. The patient has less than maximally dilute urine, so the patient has more urinary osmolality of more than 100, already discussed many times. There is an elevated urinary sodium excretion more than 30. Some books say more than 40. There's an absence of advanced kidney disease or cirrhosis or heart failure, already told you. Absence of other cause of euvolemic hyponatremia like glucocorticoid deficiency, hypothyroidism, or diuretic use, because this is a diagnosis of exclusion. When you have excluded other causes, then only you think of SIADH. And other criteria, that is, you have a serum uric acid of less than 4, there is hypouricemia, you have a fractional, because there is hyperuricosuriia, you have a fractional excretion of uric acid which is more than 10%. There is worsening of hyponatremia with IV saline, and the plasma vasopressin or the copeptin levels are increased up inappropriately, and abnormal response to water load. Of course, that's pretty easy. These are the different formulae which you use for measuring the sodium deficit and what is the infusion rate and what is the plasma osmolality. But I'm not a big fan of these formula. I try to do it with my own concepts. Okay. And I'll teach you what to do and how to do. Now, let us take another case, and this will further deepen your concept about two very important entities of hyponatremia, and you will further understand this. A 55-year-old man underwent transnasal endoscopic resection of a pituitary adenoma. On day 2, the serum sodium was 130. He was, despite continued volume expansion with sodium chloride at 75 ml per hour and stress dose of glucocorticoid. So he was being given NaCl and still his sodium was dropped to 130. On the next day, it fell to 126. The patient became somnolent. The urine osmolality was 626 milliosms per kg, and the urinary sodium was pretty high, 262. There was hypouricemia, uric acid less than 4, normal blood pressure, normal creatinine. The serum sodium falling from normal to 130 to 136, and the urine osmolality pretty high, hypouricemia. The patient was started on 3% sodium chloride with sodium chloride tablets, and the patient was continued with isotonic saline, and the sodium decreased to 123. Now, please understand here the total body sodium is increasing because you are infusing more and more of sodium in the body, but the sodium concentration is decreasing. I hope you have understood with this beautiful example the difference between total body sodium content and the sodium concentration. The sodium concentration decreased further and the patient became drowsy, poorly responsive, despite having received so much 26.25 grams of sodium chloride during that period. What are your comments? Can I expect a few comments? What do you think it is and how will you approach this patient? After any brain surgery or any brain traumatic event, there are two important causes of hyponatremia. One is SIADH, and the second is your cerebral salt wasting. This is so important, and let me tell you, despite teaching you all the theories, it could be very difficult to discern this clinical entity in private practice, in your absolute practical experience, because it is quite difficult. And I'll tell you what is that which I resort to while seeing such a patient. So how do you differentiate between cerebral salt wasting and SIADH? Now, please understand, cerebral salt wasting is what? What is the mechanism? The mechanism is if there is any neurological event, what happens? There is release of brain natriuretic peptide from the brain, and there is sodium loss. What happens in SIADH? In any neurological event, there is increase in ADH. ADH causes what? Increase in water reabsorption, and that causes a dilutional hyponatremia. I've already discussed how it causes what? It also causes increase in urinary sodium excretion by expanding the ECV. Very good. Now, this is the mechanism. What happens to the volume status of this patient? If you carefully notice, the cerebral salt wasting will have a hypovolemic status, whereas SIADH will have a euvolemic status. What happens to RAS? The RAS in cerebral salt wasting is activated. In SIADH, it is suppressed. What happens to uric acid? My dear students, it is low in both, which is the most frequently given wrong answer. Hypouricemia is a feature of both CSW and SIADH. Please understand this. And also remember, both are hypoosmolar hyponatremia. That is, both are true hyponatremia. Don't think that one is a pseudo or one is a hyperosmolar hyponatremia. No, both are true hyponatremia because both have a serum osmolality of less than 275. I hope I'm absolutely clear here. So, sir, it is getting quite difficult for me now because it's only the volume status, which is clinically sometimes pretty difficult to judge in an ICU. What do I do then? Then, what will I do is the treatment. What is the treatment of cerebral salt wasting? The treatment is fluid therapy. The treatment is IV normal saline. And what is the treatment of SIADH? The treatment is free water restriction. What happens after giving NS or sodium chloride? If the patient improves, it is cerebral salt wasting. If the patient worsens, it is SIADH. Because, sir, SIADH may you restrict free water, you don't give water, you don't give saline. So this is pretty much what is sometimes resorted to in practical scenarios. Sir, whatever you have a gut feeling, go with it and start treating. If the patient improves with that, it is probably that. If it does not, it is the opposite. Such is the close proximity of these two disorders. Sir, anything else which is very, very important? Yes, which is quite favorite of your INISS people also. Important for MCQ also. Because hypouricemia is present in both. So what is that? Your hypouricemia, remember, it persists even after sodium correction. But here it becomes normal after treating hyponatremia. Your fractional excretion of phosphate. So there is phosphaturia more than 20% in cerebral salt wasting, but it is normal in SIADH. So there is increased excretion of phosphate in cerebral salt wasting, but it is normal in SIADH, which is very, very important to differentiate between these two. I hope the concept between these two disorders is absolutely clear for you all. Okay. Now, this actually class could be on and on because hyponatremia is, I usually teach, especially to the MD/DM students, a lecture of around 4 to 5 hours. But I just wanted you to have a glimpse of how and what lectures we are preparing for you at the PG residency curriculum and how the practical approach to hyponatremia, the flowchart to hyponatremia, and what is done. So I don't want to make it a very, very long video. Thank you so much for your patient listening. Any questions are welcome. I will give you my WhatsApp number. This is my WhatsApp number and this is my email ID. Okay. I hope that you have understood. I will also give you my Instagram ID, where I try to post regular updates. The underscore kidney doctor. So I expect to connect with you all. You will find this video in the Doc Tutorial Super Speciality channel on YouTube. You can go there, resort to it again and watch it and ask any questions subsequently also. Thank you so much. And I welcome all the PG students of MD DNB to join our course and for the benefit. And it will be a mutually learning experience. Thank you so much.